Thanks again, Stace, for that great presentation. Welcome and thank you, everyone, for taking time out of your busy schedules to come today. What we're going to be discussing for those who are on the webinar is the Home Health Quality Reporting Program requirements, definitions, and assessments. And I just want to also give a little bit about my background. Previously to being a nurse researcher at Apt Associates, I was a home health clinician. I was a med-surg home health clinician, a behavioral health home health clinician. I worked as a quality improvement and compliance nurse, and before I left, I was overseeing a utilization department, so I fully understand where you guys are from your perspective. So my hope for today's presentation is that you'll be able to describe the data submission requirements and consequences of failing to meet the pay for reporting performance requirement, identify the 5 Impact Act quality measures finalized for inclusion in the Home Health Quality Reporting Program, which begins January 1st, 2017, identify the measures to be removed from the Home Health Quality Reporting Program and the Home Health Quality Initiative, and that's starting in January as well. Also, I want to show you guys where you can identify and locate OASIS C2 resources to include the posted data set, manual, question and answers or Q&As, along with the Home Health Quality Reporting Program and the Home Health Quality Initiative measure tables and specifications. Define the following terminology associated with the Home Health Quality Reporting Program, because again, what I'm doing in this presentation is kind of giving you the building blocks for the rest of the day and tomorrow. So we're going to go over numerator, denominator, outcome and process measures, quality measure calculation algorithm, and risk adjustment. And for those of you that this is a bit new to, brace yourself. I've tried to break it down so that it's pretty straightforward, as well as give a little bit more information for those of you who might be experts in quality measure specifications. Lastly, we'll review the OASIS time points and assessments. The reporting of quality data by home health agencies is mandated by Section 1895 of the Social Security Act. This statute requires that each home health agency shall submit to the Secretary such data that the Secretary determines are appropriate for the measurement of healthcare quality. Such data shall be submitted in a form and manner and at a time specified by the Secretary for purposes of this clause. OASIS reporting is mandated by the Medicare regulations at Part 42 of the Code of Federal Regulations, which requires agencies to submit OASIS assessments and home health care consumer assessment of healthcare providers and system surveys, better known as HHCAPS, data to meet the quality reporting requirements of Section 1895 of the Act. Section 1895 of the Act states that for 2007 and each subsequent year, in the case of home health agency that does not submit the data to the Secretary, in accordance with subclause 2, with respect to such a year, the home health market basket percentage increase applicable under such clause for such year shall be reduced by 2 percentage points. The home health quality reporting performance system is driven by the principle that each home health agency will be expected to submit a minimum set of 2 matching assessments for each patient admitted to the agency. These matching assessments together create what is considered a quality episode of care, which would ideally consist of a start of care, or a SOC, as a lot of us call it, or a resumption of care, or a ROC, and a matching end of care assessment. However, there are several scenarios that could meet this matching assessment requirement of the pay for reporting performance requirement. These scenarios have been defined as quality assessments, which are defined as assessments that create a quality episode of care during the reporting period or could create a quality episode if the reporting period were expanded to the earlier reporting period or into the next reporting period. Bear with me. 7 types of OASIS assessments submitted by a home health agency will fit this definition of a quality assessment. So the first one is what we typically think of as a quality assessment. So it's a SOC or a ROC assessment that has a matching end-of-care assessment. End-of-care assessments are assessments that are conducted at transfer to an inpatient facility with or without discharge, death, or discharge from home health care. These 2 assessments, the SOC or ROC assessment and the end-of-care assessment, create a regular quality episode of care, and both count as quality assessments. A SOC-ROC assessment that could begin an episode of care but occurs in the last 60 days of the performance period, we call this a late SOC-ROC quality assessment. An end-of-care assessment that could end an episode of care that began in the previous reporting, that is, an end of care that occurs in the first 60 days of the performance period, we call this an early end of care quality assessment. A SOC-ROC assessment that is followed by 1 or more follow-up assessments, the last of which occurs in the last 60 days of the performance period, we call this a SOC-ROC pseudo-episode quality assessment. An end-of-care assessment is preceded by 1 or more follow-up assessments, the last of which occurs in the first 60 days of the performance period. This is called an end-of-care pseudo-episode quality assessment. A SOC-ROC assessment that is part of a known 1-visit episode, we call this a 1-visit episode quality assessment. SOC, ROC, and end-of-care assessments that do not meet any of these definitions are labeled as non-quality assessments. Follow-up assessments, that is, where the MU 1000 reason for assessment is a 4 or a 5, are considered neutral assessments and do not count towards or against the pay for reporting performance requirement. And I'll just share that in this presentation, at the very end, we have a lot of downloads to include this information. So if you didn't catch all of that, you can find it in the downloadables of the URLs that we'll give you. In the calendar year 2015 Home Health Final Rule, again, which will be available in the links within this presentation, CMS proposed to establish a new pay-for-reporting performance requirement with which provider compliance with quality reporting program requirements can be measured. And why was this proposal done? Let me give you some reasons why. First, it was believed that defining a more explicit performance requirement for the submission of OASIS data by agencies would better meet Section 5201 of the Deficit Reduction Act of 2005. And so that states that each agency shall submit to the Secretary such data that the Secretary determines are appropriate for the measurement of healthcare quality. Such data shall be submitted in a form and manner and at a time specified by the Secretary for the purpose of this clause. And then secondly, in February of 2012, HHS Inspector General, fondly known as OIG, as we all know, performed a study to, 1, determine the extent to which home health agencies meet federal reporting requirements for OASIS data, 2, determine the extent to which states meet federal reporting requirements for OASIS data, and 3, determine the extent to which CMS oversees the accuracy and completeness of OASIS data submitted by home health agencies. In a report entitled Limited Oversight of Home Health Agency OASIS Data, the OIG made a finding that CMS did not ensure the accuracy or completeness of OASIS data. The OIG recommended that CMS identify all home health agencies that failed to submit this OASIS data and apply the 2% payment reduction. CMS believes that establishing a performance requirement for submission of OASIS quality data would be responsive to the recommendations of the OIG. So here, you've got a visual. Compliance with the pay-for-reporting performance requirement can be measured through the use of an uncomplicated mathematical formula. This formula is titled Quality Assessments Only, or QAO, because only the OASIS assessments that contribute or could contribute to creating a quality episode of care are included in the computation. Again, we reviewed some of those possible scenarios. If you want to get a little more detail on this, again, we'll go into some of the related links that you can use, but it's on cms.gov Home Health Quality Reporting Requirements website. And so, for episodes that began on or after July 1st, 2015, and before June 30th, 2016, agencies had to score at least 70% on the QAO metric for pay for reporting performance or be subject to a 2 percentage point reduction to their market basket update for calendar year 2017. The national provider level of compliance for this time period was approximately 96%. Only 449 home health agencies failed for OASIS, or about 4%. For episodes that began on or after July 1st, 2016, but before June 30th, 2017, agencies are required to score at least 80% on the QAO metric of pay for reporting performance or be subject to the 2 percentage point reduction in their market basket update for calendar year 2017. And so, what is the ultimate goal for this program? To require agencies to achieve a quality reporting compliance rate of 90% or more, as calculated using that QAO metric that we reviewed. This performance rate will be in effect for episodes that begin on or after July 1st, 2017. CMS established the Home Health Compare website on Medicare.gov as a key tool for consumers to use when choosing a home health care provider. It's designated to be an easy-to-access, convenient source of authoritative information on provider quality. One of the two types of star ratings for home health is the Quality of Patient Care Star Ratings, which is based on OASIS assessment and Medicare claim data. These ratings were first published on Home Health Compare, July 1st, 2015. The Quality of Patient Care Star Ratings methodology includes 9 of 24 currently reported process and outcome quality measures. These measures were chosen based on the following criteria. The measure should apply to a substantial proportion of home health patients and have sufficient data to report for a majority of home health agencies. The measure should show a reasonable amount of variation among home health agencies and should be possible for a home health agency to show improvement in performance. The measure should have a high face validity, so basically it should do what it looks like it's telling you it's doing, and clinical relevance. The measure should be stable and not show a substantial random variation over time. And the measure should be stable and not show substantial variation, random variation over time. So the 9 measures selected based on these criteria, the process measures are timely initiation of care, drug education on all medications provided to patient or caregiver, influenza immunization received for the current flu season, and then the outcome measures are improvement in ambulation, improvement in bed transferring, improvement in bathing, improvement in pain interfering with activity, improvement in shortness of breath, and acute care hospitalization. So here we have this slide again that Stace referred to. I'm just going to go into a little bit of detail because I think it's worthwhile for all of you to get a sense of what's going on here for home health agencies. If you look at the very top blue box, that's going to give you, it's the Legend for Impact Act, A through H, and it gives you all of the Impact Act domains that are going to be covered over the next few years. If you come down to the bottom of the slide under the Impact Act milestone, so what we're looking at is that red bar that goes across the slide. You can see that home health agencies start reporting measure data for domains B, C, F, G, and H. And what are those domains? Skin integrity and changes in skin integrity, medication reconciliation, resource use measures, including total estimated Medicare spending per beneficiary, discharge to community, all condition potentially preventable hospital readmission rates, and this starts January 1st, 2017. If you go right above that red bar, you're going to get to the Impact Act milestones, and you can see that agencies start reporting measure data for domains A, D, and E, and those are functional status, cognitive function, changes in function and cognitive status, incidence of major falls, transfer of health information and care preferences when an individual transitions, and as Stace had said, these start January 1st, 2019. Also, if you keep going right on that document, please note the accompanying timelines for confidential feedback reports, preview reports, public reporting for each respective initiation of the quality reporting period. So I highly recommend taking some time to look at this slide. And again, we've got a recap of the 2017 Impact Act reporting requirements as well as the effective date for OASIS C2, which supports calculation of the impact measures. So to the question that we received earlier, that's what's going to help support these measures. In November 2015, CMS released the calendar year 2016 final rule to include the first finalized Impact Act quality measure, a cross-setting pressure ulcer measure to satisfy the Impact Act measure domain, skin integrity and changes in skin integrity. This quality measure reports the percent of patients with stage 2 to 4 pressure ulcers present as discharge that are new or worsened since the beginning of the quality episode. Again, quality episodes are defined by pairing a start or a resumption of care assessment with an end of care assessment. Those are the traditional quality assessments that we think of. For home health patients, the measure is calculated by examining one OASIS item on the discharge assessment, which reports the number of current stage 2 through 4 pressure ulcers that are present at discharge, but that were not present or were at a lesser stage at the beginning of this quality episode. There will be a presentation tomorrow going into detail about this measure. Just this month, CMS released the calendar year 2017 final rule. CMS has adopted 4 measures to meet the requirements of the Impact Act. And here they are on the screen: potentially preventable 30-day post-discharge readmission measure, total estimated Medicare spending per beneficiary, discharge to the community, and drug regimen review conducted with follow-up for identified issues. So here, we have this quality measure as a process measure that reports the percentage of patient care episodes in which a drug regimen review was conducted at the time of the start of care or resumption of care, and timely follow-up with a physician occurred each time potentially clinically significant medication issues were identified throughout that care episode. Again, there'll be a presentation tomorrow going into detail about this measure. And so here we have the 3 finalized impact quality measures, which are claims-based measures. We already have some claims-based measures. We will add to those with these. For the quality measure, total estimated Medicare spending per beneficiary, CMS reviewed the National Quality Forum, or NQF's, consensus endorsed measures, and were unable to identify any NQF-endorsed resource use measures for the post-acute care or PAC settings. Therefore, CMS adopted this Medicare spending per beneficiary measure under Section 1899B of the Act, which allows the agency to specify a measure that is not NQF-endorsed if the measure deals with a specified area or medical topic the Secretary has determined to be appropriate for which there is no feasible or practical NQF endorsed measure. And again, NQF endorsed measures are considered the gold standard, so that's why the Act implored us to use that as a starting point. Given the current lack of resource use measures for the PAC setting, the Medicare spending per beneficiary measure will provide valuable information to home health agencies on their relative Medicare spending and delivering services to approximately 3.5 million beneficiaries. The methodology for the construction of the measure can be found in the final rule. And again, when we look at some of the resources towards the end of this presentation, included is the final rule, which again, I highly recommend folks reading because it gives you all the information that you need. The quality measure discharge to community is an outcome measure that assesses successful discharge to the community from a home health setting, with successful discharge to the community including no unplanned hospitalizations and no deaths in the 31 days following discharge from the home health agency setting. Specifically, this measure reports an agency's risk standardized rate of Medicare fee-for-service patients who are discharged to the community following a home health episode, do not have an unplanned admission to an acute care hospital or a long-term care acute care hospital, better known as an LTAC, in the 31 days following discharge to community and remain alive during the 31 days following discharge to community. The term community for this measure is defined as home self-care on the Medicare fee-for-service claim. The measure, and again, it's based on, for the claim, the patient discharge status code would be 01 or 81. In terms of the definition of the discharge to community outcome, the approach to risk adjustment, and the measure calculation, it's uniform across the PAC settings. And then lastly, the quality measure, potentially preventable 30-day post-discharge readmission measure, is an outcome measure that assesses the facility level risk standardized rate of unplanned, potentially preventable hospital readmissions for Medicare fee-for-service beneficiaries that takes place within 30 days of discharge from a prior proximal hospital stay. And so what is that? That's defined as an inpatient admission to an acute care hospital. And so that type of admission can be an IPPS, which is your traditional inpatient prospective payment system. It can be a critical access hospital, or it can be a behavioral health hospital. Hospital readmissions, including readmissions to short-stay acute care hospital or an LTAC, with the diagnosis considered to be unplanned and potentially preventable. This proposed measure is claims-based. Because of the measure denominator, the bottom of a ratio, we'll go into detail on that, is based on home health admissions. Each Medicare beneficiary may be included in the measure multiple times within the measurement period. Readmissions counted in this measure are identified by examining Medicare fee-for-service claims data for readmissions to either acute care hospitals or LTACs that occur during a 30-day window beginning 2 days after the home health discharge. This measure is conceptualized uniformly across the PAC settings in terms of measure definition, the approach to risk adjustment, and the measure calculation. And again, that was a lot of information. If you go to the final rule, it's all there and you can read it at your leisure. In 2015, CMS undertook a comprehensive reevaluation of all 81 home health quality measures, some of which are used in the Home Health Quality Initiative, HHQI, and others that are publicly reported as part of the Home Health Quality Reporting Program. This review of all the measures was performed in accordance with the guidelines from the CMS Measurement Management System, MMS, also known as the Blueprint. The goal of this reevaluation was to streamline the measure set consistent with MMS guidance and in response to stakeholder feedback. This reevaluation included a review of the current scientific basis for each measure, clinical relevance, usability for quality improvement, and evaluation of the measure properties to include reportability and variability. CMS's measure development and maintenance contractor for home health, us, Apt Associates, convened a technical expert panel. Stace had talked about that earlier. It's called the TEP, on August 21st, 2015. And so what we did there with that group of stakeholders from the community was review and advise on the reevaluation results. The TEP provided feedback on which measures are most useful for patients, caregivers, clinicians, and stakeholders, but also on analytics provided, an environmental scan of all the literature that's out there today on home health. So all of that information was taken together to help advise what would be removed from the 81 measure set. CMS identified 28 home health quality initiative measures that were either topped out, so they had limited variability, they weren't really changing much, and or determined to be of limited clinical and quality improvement value by these TEP members. Therefore, these measures will no longer be included in the Home Health Quality Initiative beginning on January 1st. Again, the key distinction between the Home Health Quality Reporting Program and the Home Health Quality Initiative is that home health quality reporting measures are publicly reported, while Home Health Quality Initiative measures are not publicly reported. So the 6 home health quality reporting measures will be removed from the home health quality reporting and public reporting starting January 1st. All 34 measures that are to be removed, both the Home Health Quality Initiative and the Home Health Quality Reporting Program, will be removed from all non-demand home health agency level CASPR reports in 2017. But patient-level data will still be available on the tally reports for agencies to utilize for quality improvement. Again, we're going to go into detail about data submission and reporting requirements tomorrow. So if you don't know what CASPR is, you will tomorrow. In the calendar year 2017 rule, CMS defined the term remove to mean that the measure is no longer a part of the home health quality reporting measure set. Data on the measure would no longer be collected for purposes of home health quality reporting, the Home Health Quality Reporting Program, and that the performance data for the measure would no longer be displayed on Home Health Compare. CMS also finalized the decision to use the following criteria when considering a quality measure for removal. 1, the measure performance among home health agencies is so high and unvarying that the meaningful distinctions and improvement in performance can no longer be made. 2, performance or improvement on a measure does not result in better patient outcomes. 3, a measure does not align with current clinical guidelines or practice. 4, a more broadly applicable measure across settings, populations, or conditions for the particular topic is available. 5, a measure that is more proximal in time to desired patients' outcomes for the particular topic is available. And then 6, a measure that is more strongly associated with desired patient outcomes for the particular topic is available. The items used in calculation of removed measures may still appear on OASIS for previously established purposes that may not be related to the Home Health Quality Reporting Program. In addition, agencies will be able to access this data for these items using the CASPR system and will be able to use the information for their own monitoring and quality improvement efforts. Further, CMS defined replace to mean that it would adopt a different quality measure in place of the currently used quality measures for one or more of the reasons described above. Finally, CMS finalized that such removal or replacement would take place through notice and comment rulemaking unless it's determined that a measure was causing concern for patient safety. Specifically, in the case of a home health quality reporting measure for which there is a reason to believe that the continued collection raised possible safety concerns or would cause other unintended consequences, CMS will promptly remove the measure and publish the justification for the removal in the Federal Register, the final rule, pre-rule, during the next rulemaking cycle. In addition, such circumstances, CMS will immediately notify home health agencies and the public through the usual communication channels, which include special open door forums, home health open door forums or listening sessions, memos, email, notification, and web postings. In addition, based on the results of the comprehensive reevaluation and the TEP input, CMS will remove 6 process measures from the home health quality reporting program, beginning with the calendar year 2018 payment determination. Because they are topped out, again, there's little variation in these measures. These 6 measures are different than the 28 measures that will no longer be included within the Home Health Quality Initiative. Items used to calculate one or more of these 6 measures may still appear on the OASIS for previously established purposes that are not related to the Home Health Quality Reporting Program. These removed measures will no longer be reported on Home Health Compare, again, starting with the January 2017 refresh. So we have these here. It's pain assessment conducted, pain interventions implemented during all episodes of care, pressure ulcer risk assessment conducted, pressure ulcer prevention and plan of care, pressure ulcer prevention implemented during all episodes of care, and heart failure symptoms addressed during all episodes of care. Home Health Compare has information about the quality of care provided by Medicare-certified home health agencies throughout the nation. Medicare-certified means the home health agency is approved by Medicare and meets certain federal health and safety requirements. Home Health Compare can help a consumer and their family or caregiver choose a quality home health agency that has the skilled home health services that they might need. The information on Home Health Compare helps the consumer learn how well home health agencies care for their patients. It shows the consumer how often each agency uses best practices when caring for its patients, and whether the patients improved in certain important areas of care. And it shows the consumer what other patients said about their recent home health care experience. As noted previously, patient-level data for all removed measures will still be available on the tally reports, which are through Casper, but not on the other quality measure reports. In addition, due to processing constraints, results for the 6 removed home health quality reporting measures will still appear on Home Health Compare preview reports, although not on the Home Health Care website for at least one more refresh cycle. So here we have the process measures that will be removed. Depression interventions and plan of care, depression interventions implemented during all episodes of care, fall prevention steps and plan of care, fall prevention steps and implemented for all episodes of care, pain intervention in the plan of care, pressure ulcer treatment based on principles of moist wound healing in a plan of care, treatment of pressure ulcers based on principles of moist wound healing implemented during all episodes of care, and then physician notification guidelines established. And we continue, there's more to be removed. 3 process measures, so it's drug education on high-risk medications provided to patient or caregiver at the start of episode, potential medication issues identified and the timely physician contact at start of episode, potential medication issues identified and timely physician contact during all episodes of care, emergent care for an injury caused by a fall. We also have 2 potentially avoidable events, or PAEs, that are going to be removed, and that's emergent care for injury caused by fall and emergent care for wound infections, deteriorating wound status. And then we move on to the outcome measures that'll be removed. Improvement in anxiety level, improvement in urinary incontinence, improvement in behavioral problem frequency, improvement in speech and language, improvement in urinary tract infection, improvement in grooming, improvement in toileting hygiene, improvement in eating, improvement in light meal preparation, improvement in phone use. Stabilization in speech and language, stabilization in cognitive functioning, stabilization in anxiety level, stabilization in light meal preparation, and stabilization in phone use. To reiterate, these measures will be removed from all on-demand agency-level quality measure CASPR reports in 2017, but patient-level data will still be available on the tally reports for agencies to utilize for quality improvement. There will be a presentation tomorrow, again, going into detail on data submission and reporting in CASPR. So, let's move on to some poll questions. You should each have a little tool on your desk for you to be able to answer. So the minimum quality reporting compliance rate for the performance period of July 1st, 2016 through June 30th, 2017 is, and we'll give you some time, you'll see a countdown there. And you can answer as a group if you all talk together at the table. How are we doing? Has everyone submitted? Do you need some more time? You ready for the answer? There you go. I heard people shout it out. B. The answer is 80%. So is everyone comfortable with how to use the poll? Just press it when you all decide at your table. So why don't we go on to another question? Home health agencies with compliance levels below 80% for the performance period of July 1st, 2016 through June 30th, 2017 will see a 2 percentage point reduction in their APU for the calendar year 2018. Is this true or is this false? We'll give you 30 seconds to count it down and use your little machine to point so that we can collect everyone's answers. All right, why don't we see what that answer is? Oh, 94% said true. Excellent. Great job, everyone. All right, we've got one more poll question to check your knowledge. The Home Health Quality Reporting Program quality measure adopted in the calendar year 2016 final rule is, we'll give you a 30-second countdown for you guys to talk amongst each other on the table, and then click and point. Everyone ready? Not yet? I still hear people talking. Why don't we take a look-see and see what the answer is? Oh, okay. D. Percent of residents or patients with pressure ulcers that are new or worsened. So those other measures were just put into the calendar year rule this year. So that's where you'll probably go in there and get a little more detail. Okay? So let's move through to some more information. So again, depending on your measure knowledge, let's learn or review some key terms for understanding quality measures and measure terminology. Again, these are what you can think of as the building blocks for quality improvement measures, so that you can get a sense of how they're developed. So specifically, we're going to cover numerator, denominator, outcome and process measures, complete quality episodes, the quality measure calculation algorithm, and risk adjustment. So again, you're going to hear these terms in your other presentations today and tomorrow. So again, National Quality Forum, or NQF, tends to be where we get a lot of our guiding information about measures. And they indicate measure specifications are the technical instructions for how to build and calculate a measure. They describe a measure's building blocks, again, numerator, denominator, exclusions, or what you wouldn't consider in the denominator, target populations, how results might be split to show differences across groups, or a way to stratify those populations, risk adjustment methodology, how results are calculated, calculation algorithm, measure specifications, sampling methodology, data source, level of analysis, how data are attributed to a provider or an agency, so an attribution model, and the care setting. Taken together, measure specifications are a blueprint that tells you guys how to properly implement the measure within your organization. A healthcare performance measure is a way to calculate whether and how often the agency does what it should. Measures are based on scientific evidence about process, outcomes, perceptions, or systems that relate to high-quality care. The result of a measure is usually shown as a ratio or a percentage. So you've got your line with your top number and your bottom number, numerator, denominator. If you have a question about the health of a community or a group of people, or how well an agency is performing, a measure can provide important information. And so for the purposes of healthcare quality, you can think of the numerator as the number of patients or healthcare episodes included in the denominator, the bottom number, where the care process for a process measure was delivered, or the patients experienced the specified outcome. The denominator, the bottom number, is the number of patients or episodes eligible for the process or the outcome. So again, in home health, we have today process and outcome measures. Process measures evaluate the rate of an agency's use of specific evidence-based processes of care. The Home Health Quality Reporting Program and the Home Health Quality Initiative process measures focus on high-risk, high-volume, problem-prone areas for home health care. And these include measures pertaining to all or most home care patients, such as timeliness of home care, admission, immunizations, and the use of risk assessment tools for falls, pain, depression, and pressure ulcer development. There are also measures for specific diagnoses, such as heart failure, diabetes, pressure ulcers, and measures of care planning and clinical interventions delivered for patients experiencing certain symptoms, such as pain, depression. Process measures are derived from data collected in the OASIS submitted by home health agencies and are calculated using a completed episode of care, which we really went into detail there earlier in the presentation. Unlike the outcome measures, process measures are not. They're not risk adjusted. And why is that? Risk adjustment isn't considered necessary because the processes being measured are appropriate for all patients included in the denominator, the bottom number. Patients for whom the measure is not appropriate are excluded. And again, what we said is, and we'll go into some detail on that, there are exclusions for that bottom number or denominator that take out those patients that wouldn't be counted in your measure total. So then we have outcome measures, and they're used to assess the results of health care that are experienced by patients. And the data for Home Health Quality Initiative and Home Health Quality Reporting Program outcome measures are derived from two sources. So you've got OASIS, but then you also have the data submitted from Medicare claims. Measures based on OASIS data are calculated using a completed episode of care. Again, those are those 7 variations that we had talked about earlier in the presentation. Measures based on home health claims data are calculated based on the first home health claim that starts an episode of care for a patient and end either in 30 or 60 days after the initial claim. There are 3 types of outcome measures used in the home health quality reporting program, and they are improvement measures, so in other words, measures describing a patient's ability to get around, perform ADLs, and general health. Measures of potentially avoidable events, so in other words, these are the markers for potential problems in care, things we probably don't want to have happen. And then utilization of care measures, measures describing how often patients access other healthcare resource uses, either while in-home care is in progress or after home care is completed. Here we've got some information that's related to interpreting process and outcome measures. For measures reported as a ratio, again, you've got your line, your numerator, your denominator. A higher denominator, the bottom number, reflects better quality for a desirable care process or a positive outcome. Alternatively, a smaller numerator, again, the top number, indicates better quality for an undesirable care process or an adverse outcome. So here, we've got an example for those of you who, if we want to try and make it really crystal clear and fairly simple. So say you've got 10 cookies, 3 of which are chocolate chip cookies, okay? So that top number is the numerator, and that's your 3. The bottom number under the line is the denominator, and that's 10. So if you divide the numerator by the denominator, or 3 out of 10, you get 0.3. And then to get a percentage, you multiply that by 100. So there are 30% chocolate chip cookies. It really is pretty as straightforward as that for all the measures. You're looking at a numerator, a denominator, and most of them, all of them, I believe, are reported as a ratio. So let's talk about another more healthcare-related example, and this is from NQF. Once a person has had a heart attack, taking aspirin daily has been shown to reduce the chance of having a second heart attack. Guidelines tell physicians to prescribe aspirin to all patients leaving the hospital after a heart attack. This practice can be measured with higher percentages indicating better performance. So say you have 100 total heart attack patients, your denominator, and of those patients, 96 were prescribed aspirin at discharge, your numerator. So you'd be able to say that 96% of the patients experience the best practice of aspirin prescription at discharge. Does that make sense? Okay. As we have previously mentioned, measures based on OASIS data are calculated using a completed quality episode of care that begins with an admission to an agency or a resumption of care following an inpatient facility stay and ends with a discharge or transfer to an inpatient facility or death. Again, that's your typical quality assessment, but we also reviewed some other potential quality assessments as well earlier in the presentation. Failure to submit sufficient OASIS assessments to allow calculation of quality measures, including transfer and discharge assessments or death, is failure to comply with the conditions of participation. The quality calculation algorithms or measure specifications that define the numerator, the denominator, exclusion, so what can we take out of that bottom denominator number because they don't really fit for that measure, and risk adjustment methodology are available on the CMS website. Again, we'll review a little bit where you can get to that, but it's a downloadable under that website. So risk adjustment, we could go into loads of detail about this, but I'm going to keep it pretty simple. Again, if you go on to the websites that we'll review towards the end of the presentation, you can get as much detail as you want about risk adjustment. But basically, we've got 3 types of risk adjustment that will be touched upon in greater detail in the other presentations, both today and tomorrow. You've got exclusions. Again, we're taking some of those patients out. Patients whose outcomes are not under the agency control, or for whom the outcome may be unavoidable or not relevant, are removed from calculation. And again, some general exclusions that we have for home health, patients under 18, maternal child health patients, you know the general ones. Again, it's on the home health website. Stratification. Patients with similar risks for outcomes based on their clinical characteristics are grouped together, and the measure is calculated separately for each group. So that's what we talk about by stratifying or separating out those different groups. Covariates. Patient characteristics that may affect risk for certain outcome. One that would come to the top of my head here as I'm speaking is perhaps a patient who is experiencing urinary incontinence, might be at risk for falls. So again, what characteristics might affect the risk of certain outcomes? Again, here we just have a review of the OASIS time points that we use in home health. OASIS data are collected at the following time points. So again, start of care, SOC, resumption of care following an inpatient facility stay, again, some of us call it a ROC, recertification within the last 5 days of that 60-day recertification period, other follow-up during the home health episodes of care, transfer to an inpatient facility, discharge from home care, or death at home. For the start of care, the comprehensive assessment should be completed within that first 5 days after the start of care date. For a resumption of care, the comprehensive assessment must be completed within 48 hours of return home after that inpatient facility discharge. The following assessments must be completed within 48 hours of your agency becoming aware of disposition. So disposition is kind of a fancy word for where the patient went. So it's a transfer to an inpatient facility, discharge from home care, death at home, or an other follow-up. So here we've got some great resources CMS has put on their website at the following URL. So basically, if you go to cmshomehealth.gov or cms.gov and you can follow through with these different add-ons, you're going to get to a website page that on the left-hand side has all the different possible pieces with home health. You've got the home health quality reporting program, you've got OASIS, all sorts of information. And if you scroll all the way down to the page, you'll see in a box at the bottom the downloadables. That's where you can actually pull down all of the information. Everything I talked about today is somewhere within those downloadables. I just put it into an easier package to go along with the slides. So you'll have the OASIS C2 guidance manual and the OASIS C2 item set, which is effective January 1st, 2017. Again, we've got some more resources on OASIS. The OASIS C2 Q&As have been posted under the OASIS User Guide and Trainings page. So I'm going to call out a URL now if people want to grab their pen. So at https semicolon or colon 2// www.qtso.com/ hhatrain.html is the specific website. And if you didn't get that, we can probably put that up again later, okay? Yeah, gotcha. Yep, I can repeat it. What, you ready to go again? Everyone have their pen? So it's https colon, the 2 dots, 2/ www.qtso.com/ cms.HATRAIN.HTML. And if you didn't quite catch that, we can post that. So again, we have some more information for you to download, and I'm not sure, is everyone familiar with these measure tables? We have the new ones posted in December for OASIS C2. So you've got an outcome set, a process measure set, and then a potentially avoidable events, PAEs measure set. These are very helpful as far as if you're working on quality improvement in your agency. Again, some more valuable CMS resources for OASIS educational coordinators, which are state by state. Each state has designated an OASIS educational coordinator with the responsibility to ensure that all home care providers in the state have access to, 1, training in the OASIS dataset administration for assessing patients, 2, training and technical support in integrating the OASIS items in the agency's record-keeping system, and 3, technical support in answering questions on the clinical aspects of OASIS. Home health quality reporting information and the contacts for the QSO, that's QTSO, help desk, are here on this slide. Again, I thank you for your time. I know how busy all of you are, and I just want to give you a reminder to take a few moments to jot down any to-dos that might have come up during this presentation on your action plan. And now I'm happy to entertain any questions. Do you want to use the micro? Let me use the microphone. I think there's one. Okay.
How are we going to be measured for the total cost of estimated claims data? And how will we be aware of what that is?
So, you're talking about the 3 new claims-based measures, Medicare spending per, yeah. So I highly advise you to go to the final rule. We don't have finality on those measures yet, so if you submit that question, I think it's something we can circle back to.
And if a patient is readmitted, but they're readmitted to a SNF, that doesn't count against us?
For that measure? Yeah, I would submit that as a question. Yep. Mark, I think we've got a question up there. Oh, sorry. I can't see with this light.
Adora Nora, KOC Healthcare Services. My question is, when we have this 2% reduction in pay, will CMS notify the agency that they are put on the 2% reduction? Are we notified that when that is being done?
You know, I'm going to follow up with CMS on that. I do believe that you are notified, but we can put a formal response to that. Does CMS want to put a
Also, and then my second question is this. On that 2% reduction, you said it's based on accurate completion of OASIS data, which includes time. That depends on when you submit to your OASIS, if it's timely submitted, and what other issues come into play, just in a simpler time for that 2% reduction.
So for the performance, pay for performance quality assessment diagram that we talked about, you've got to have those matching quality assessments and meet that percentage goal, which again, we're talking about 80%, and that's what will determine whether or not you have a 2% reduction in the APU.
So it involves, like you said, the SOC,
Yep.
EOC.
Yep. If you go online to the cms.gov website, If you go into pay for reporting, I believe that's an actual pick topic in the left column, you'll get all the information you ever wanted to know about the pay for performance reporting requirement.
Hi, Nicole. Tricia from RBC Limited.
Hi.
Thanks for the information. Now, is the risk adjustment system being updated, and is it posted on the website for the OASIS C2?
Can I speak to that? It's in the process of being updated. It's not posted yet.
Okay, thanks.
Yep. Thank you so much, everyone. Take care.